We now introduce the next dynamic speaker of our session. She is the clinical head of the anterior segment cataract, corneal, and phaco developmental program and clinical research at the Bachuwali Eye Hospital, Mumbai. She is currently the Maharashtra State Head for Women Ophthalmic Society. She is a renowned phaco teacher and has mentored over 800 doctors over the last decade. We would like to introduce none other than Dr. Suvira Jain. Ma'am, over to you.
Good evening, all. And thank you for inviting me, Pooja, to be a part of this session. And as you requested, I'm going to talk to you about how one can get started with phacoemulsification. So there is no doubt in any of our minds that phacoemulsification is the gold standard, is the only way forward for moving ahead with cataract surgery in the current day scenario, and it's here to stay. Therefore, learning phacoemulsification actually needs to be an integral part of each and every postgraduate training program. And I'd like to share with you a few points in how you can actually make that turn from a dream for most aspiring students to a reality. Education, my friends, is not really about learning facts and reproducing them, but it's about training the mind to think. At the outset, I'd like to say that, even before you're so anxious, students come and they're ready to go. The first and foremost, they need to do their groundwork and get hold of enough data that they can look at. And as Dr. Devkan said, this is the best time. Everything is online and everything is possible. You can't discount the importance of books, what I call the practical theory aspects, of course, the phaco-dynamics and understanding the setup of machines, venturi versus peristaltic. All that can be learned from books. But there are also many textbooks that show you in a practical theory way. They will show you how steps are to be done. Of course, the best way of actually doing it is observing surgeries. And I would suggest that all of us know that we can go to so many people and watch them operate online on YouTube on their particular channels. And I think it's very important to take the ones with the voiceovers because you actually understand what it is they're trying to say. I think even in your institutes as students, you should always talk to your seniors if you can get a possibility of, sitting, watching, observing your seniors at work. And yes, they may not want to be disturbed when you're operating, but you can note what they're doing, pick up what they're saying, and always catch them for a few minutes later and learn from them what was something different, what was a question you had, what was something new in a step that you observed, and they would be more than willing to see your enthusiasm and teach you whatever you could. Clearly, each and every case that you watch is going to teach you something else because even that master surgeon with each and every case is most often than not learning something else. And of course, eventually, I think it's well worth, getting into a training program where you actually learn hands-on the different skill sets that would be required to go ahead with phacoemulsification surgery. So making that transition into phacoemulsification consists of a triad of three things. One, your existing mindset and the way you need your mindset to change. What are the prerequisites you need to know and be good at even before you get started with phaco? And finally, the actual learning of the procedure itself. Now, the mindset, of course, when you just go, most students who come and tell me, listen, we've never even seen or held a phaco probe in our life. And I tell them, that's exactly why you're here. You got to be comfortable and easy. Of course, this is the point where you think it's impossible for me to get to where I want to get. I don't know. Am I ever going to be able to do it? And slowly but surely, when you start doing few of the steps and start achieving reproducibility in few of those steps, then you start understanding a little more. You get a hang of nucleus disassembly. You manage to emulsify the first nucleus. Then you manage the IA and the IOL and the complete surgery. And that's how your mindset slowly but surely shifts from impossible to being absolutely confident. As a student who's wanting to learn, it's very important to be one who understands, comprehends, and then executes rather than one who just, tend to have that mindset of jaldi se khatam karo, just finish the case and get it to the end. So there has to be a deep understanding of each and every step and why you're doing it, and not an aim to just finish it and not knowing why you're doing any step either. I think with respect to your attitude as a student, you've got to lose the fear of being wrong because in life, whether it's ophthalmology, surgery, or anything else that you're trying to learn, things are always going to be difficult before they eventually become easy. And it is so important to have the right mindset because whether you think you can do it or you can't, you're probably right. Okay. Also remember that nothing is learned in a day. It takes time to master any technique. Do not be in a hurry to learn. Be open to learning in a slow, stepwise manner. Don't worry about your colleagues, how they are learning, at what speed they are learning, because everyone has a different inherent skill set, inherent ability to learn. The learning curve can be very different for different surgeons. You have your blinders on, you follow your own path and watch yourself grow through case by case. We've already discussed the importance of taping each of your cases and just going over them with your seniors and understanding the mistakes you made there and learning from those mistakes. Mistakes will happen. But through those mistakes in each and every case, even today, I try and learn from my mistakes so I don't repeat it again. And of course, you know it's going to take more than just a few cases to become a master. Don't think too much about worst case scenario because it takes quite a bit of effort to actually create things like a nucleus drop. And of course, never listen to anyone who tells you how difficult it is. But assuming you're on the path of wanting to learn phacoemulsification surgery, these are certain prerequisites that are absolute, something that need to be done. One, you need to be very good with your binocularity and depth perception. If you've already operated SICS surgeries or extracapsular cataract surgeries, then yes, you would be, you already would have had your binocularity and depth perception. If not, take a glove, put it on a katodi and learn how to suture, learn your hand-eye coordination, binocularity and depth. You should be convinced, I guess it would be good to know some kind of surgery, whether it's extracapsular or master Emmanuel SICS cataract surgery. And I think these seem to be basic points, but I think these are very, very important. And here's what I have to say about them. Be very comfortable in how you're sitting. The first thing you need to know is, are your foot pedals comfortable? Is your chair of an adequate height that your left foot sits on your microscope foot pedal and your right foot on your phaco foot pedal, keeping a bit of an obtuse angle? Second, you make sure that the oculars are well adjusted to 0. You have the IPD set to what you want. And finally, adjust your table height to get it all together. So first, your feet and your stool. Second, the oculars and the IPD. And finally, the table height to get to where you want to be. So you have access to all instruments as well. Getting on to the surgical technique, I think you've got to understand the importance of also proper draping. You cannot underestimate. When you see eyes, as Himanshi was saying, it's going to be disturbing because you don't know what comes with those lashes. Understand the kind of lashes that you have in your center. And when you choose to put on a drape, see how it is done, wrap it the other way around, remove the plastic on the drape, and after you have used an antiseptic to clean the face, make sure it is dry. Make sure that you open out one of the lids as demonstrated here, and then introduce the drape, press the drape onto the eye. And the first place that I do press, which is not shown here, is between the inner canthus and the nose, because that's the point I want stuck on. I don't want that loose. So you stick it there with the eyes open, and as you unfurl it, you will find that you got the well-stuck drape on a dried area of the lashes over an eye that is open. And this is important, after which you cut it in the center. And again, you can cut it further before actually draping the eye. So this is another video of just the draping. Always drape such that all your lashes are completely away from the field. And do not overexpose your drape, because that can cause positive pressure and other issues there as well. When you come to making incisions, it is very important that we learn to achieve consistency in the incisions. While making your clear corneal tunnel, figure out where your main incision needs to be, figure out that it's radial to to a tangent drawn at that point of entry. Make sure you're just within the clear cornea, and make sure you get yourself a nice clear corneal tunnel. There has to be meticulous attention to wound construction each and every time. And don't be happy if you just get the main entry right. Take your time to plan. Your side port entry with a lance tip should also be equally made into a beautiful trapezoid, about 3 clock hours apart. 1 second. I think stabilization of the globe is the other point I'd like to make. You have to have a stable globe when you're making your entry. You can start with the limbs forceps, but eventually when you're going to convert to being a topical phacosurgeon, it's important to learn to use either a fixation forceps, or I'm quite happy to use a cotton bud. That makes it very, very aesthetic and less traumatic to the eye. When we talk about achieving a continuous curvilinear capsulorrhexis, there are 5 prerequisites before you even start doing your rhexis. 1, you got to make a perfect cystotome. You got to have a good illumination, a high magnification, a perfect focus on the anterior capsule, and a well insufflated anterior chamber, which completely flattens out the anterior capsule. And you have to maintain the anterior chamber depth throughout your Capsulorrhexis. You start with your rhexis. You can do it with a cystotome, with a Eutratus forceps, or with a microrhexis forceps. See the distance between your edge of the rhexis as you're creating it in the pupil, and try and maintain some uniformity. And the aim is to create a perfect rhexis. Now, what if you've got an intumescent cataract? If you've got an intumescent cataract which is tense, it's important to end up releasing some of the fluid here. So the first thing that I would say when you're doing a rhexis in an intumescent cataract is stain the anterior capsule well. Take a little extra time to stain the capsule, and use a cohesive viscoelastic to flatten out the anterior chamber and flatten out the anterior capsule. And what I'd like to do is either, I mean, this is one of the very old videos. Now I would make a tiny little rhexis, decompress the capsular bag, again insufflate with a cohesive viscoelastic, and then complete my rhexis. Now, when you're working with children, remember that the anterior capsule in children tends to be very, very elastic, and therefore be extremely cautious. Again, use a cohesive viscoelastic. And even if you aim for a smaller rhexis, you're going to always end up with a larger rhexis anyway. And when you're performing a rhexis, always hold on to the leading edge, okay? Don't pull at such a distance. Keep regrasping every 1 hour, 1 clock hour, every other clock hour, and make sure that when you end your rhexis, you end it inwards. Consistency is the name of the game. We want a 5.5 millimeter rhexis, which is well centered. And always maintain visibility of your rhexis throughout. As the flap gets bigger and bigger, make sure you move it away so that you know what it is that you are cutting. Moving on to hydrodissection. Hydrodissection ideally is a cortical cleavage hydrodissection. What I'd like to explain here is that when you're doing a hydrodissection, the first thing that you do is you remove some of the viscoelastic to give the fluid space to go. And you go in with a hydrodissection cannula exactly in the subcapsular plane, and you watch the wave go all the way around until you find a little raise. When the nucleus raises up, it means the hydrodissection wave is completed. Now, in this case, you will see both the hydrodissection as well as a hydrodilineation being performed. Just a minute, I think I've just crossed it. So when you do a hydrodissection, you are dissecting the nucleus and the cortex from the overlying capsule. When you're performing a hydrodilineation, you're bluntly injecting into the nucleus to create an endonucleus. The endonucleus then, which is what is to be emulsified during phacoemulsification. Here's another video just depicting hydrodilineation. Hydrodilineation is the one step which gives you that beautiful golden ring around it. It delineates the endonucleus and tells you what needs to be emulsified by phacoemulsification. It's also the step you'll do in a polar cataract when you want to avoid a hydrodissection. The next step that I would suggest before you get into phacoemulsification is learning how to do an irrigation aspiration. If you're a surgeon who's anyway doing SICS, manual SICS, you can suture your wound and start learning irrigation aspiration itself whilst performing SICS itself. Make sure your irrigation and your aspiration ports are of the perfect size. Make sure you don't have leaky side ports. And I would advise a bimanual as opposed to a unimanual irrigation aspiration, because it allows for a circumferential removal of cortex, because there's no question of anything being subincisional anymore. Take your time, understand your settings, and go ahead and do a good irrigation aspiration. Be careful. This is a stage where many people have problems during phaco because the phaco went well and they are extremely confident, but this is the place where you're actually working very close to the posterior capsule, and you need to exhibit significant amount of caution, care, and take enough time to achieve this. And also remember, at this point, you have to keep working with your microscope foot pedal to change your focus, as well as the phaco foot pedal to get from irrigation to aspiration. One good tip is you can insufflate your entire bag with viscoelastic, focus on the cortical sheet, and then start with your irrigation aspiration. Then you will find the need to, won't need to keep changing your focus during it. When you come to capsule polish, this is something, again, you learn much later on, but it's quite safe. with the kind of settings that all machines give you, you can just go ahead with your aspiration cannula and just ensure that the port of the aspiration cannula is not facing the posterior capsule. You just go and rub against the posterior capsule, and all this cortex that is stuck to the posterior capsule just becomes loose and just gets pulled away. Take your time to do a capsular polish, not only of the posterior capsule, but also of the remnants of the anterior capsule to reduce your chances of posterior capsular opacification. The next step that I think you should master is IOL insertion, wherein you need to understand all different lenses come with different designs, different injector systems. Call the company people, see demo videos, do a demo in loading and insertion, and make sure that when you load the lens, load it under the microscope, do it yourself. It takes 27 seconds. Do not ask your nurses to do it because they do not have any ability to see so closely. Even when you clasp it shut, look under the microscope for any end which might just be stuck over. And once you clasp the injector, the cartridge into space, under the microscope, watch for ease of mobility of the IOL up to the tip, and then inject the IOL with significant care. And once you put in your IOL, Dr. Dekan was talking about the importance of removing the viscoelastic. After you've introduced your IOL in the bag, a careful removal of viscoelastic is the next step you will do. If it's a dispersive viscoelastic, you can actually see it coming out. Make sure that you completely remove the viscoelastic because you don't want pressure spikes the next day. And if you want to wash behind the IOL, I would suggest going in with the irrigation rather than with the aspiration, because the irrigation going behind the IOL actually makes it a little safer procedure. And then train with your with your non-dominant hand, I'm left-handed, I'm sorry, let the irrigation remain in the eye, and then you hydrate your wounds to prevent significant movement of the IOL. So I would recommend you learn a good drape, a superior rectus suture if you're still doing SICS. Master your incisions, attain your, your consistency in them, hydrodissection, then the IOL loading and insertion, removal of the viscoelastic, stromal hydration, then the nucleus management, and finally the irrigation aspiration. We discussed that it is going to be a stepwise learning. When it comes to phacoemulsification, it's imperative that before you even hold the probe and sit with the patient, you understand fundamentally about the machine that you're using, understand the settings, understand the auditory signals that the machine gives you, understand the foot pedal control, what is irrigation, what is aspiration, what is phaco, understand the fluidics, understand what is power modulation and what you want to use for every particular case, understand the holding of the phaco probe, how you hold it, understand the orientation of the tip, the sleeve with respect to the tip, the patency and that it's going well, how you will hold your tubings, whether you want continuous irrigation on or not. Then you want to understand the fluidics, of course, and you want to understand the instrumentation, because now, unlike conventional cataract surgery, instead of a dialer, you're going to learn how to use a chopper into the eye. You're going to make sure that that doesn't damage either the endothelium and definitely not the posterior capsule. Understand the use of the different kind of viscoelastics and what they feel like in the eye, and certainly the IOLs. And remember that when you're doing phacoemulsification, the actual procedure of phacoemulsification, you're using your mind, your eyes, and now both hands, as well as both feet simultaneously. So that takes some time to put it all together. So before you embark on actually working with the patient, as much of the microscope foot pedal with respect to changing the focus, and the foot pedal of the phaco with respect to where you keep it, what are the sounds like, which is 1, 2, 3, master all that before you get to actually doing the surgery itself. And in terms of surgery, I mean, if it is a very soft cataract, I'd be very happy to just do a hydroprolapse and learn to do a tilt and aspiration or tilt and chop. This negates all the issues that come with, sculpting a very soft cataract, inability to chop these rubbery cataracts. So I would suggest doing a tilt and chop, which makes it a very safe procedure. Understand how much of the nuclear fragments are so soft that you can just aspirate them by in foot pedal 2 with nudging them with the second instrument. That also helps in saving the energy delivered into the eye. Removal of epinucleus with the phaco probe you should do last. Take your time, but do it with a visco expression and with irrigation aspiration. Finally, I think direct chop is the way to go because you minimize the energy delivered into the eye. There's no time wasted in sculpting. You go in there, you chop, you break it down into the number of fragments depending on how dense your cataract is, and emulsify them in a sequential manner. I think it's important to start your nucleus disassembly journey by learning a stop and chop technique, because I think we as surgeons need to know how to sculpt. Because at any point when you're doing a chop technique and you're unable to get the chop, you should know how to sculpt. For that, you need to know the dimensions of the nucleus, that it is a biconvex structure. You need to know the technique of sculpting. You need to know you go to 3, you go across, you get to 1, you get back. You need to go how your progressive sculpts need to get deeper. You need to know what the orange glow starts to look like. You need to know what is the correct kind of orange glow you want. You need to know how to then lengthen the entire groove to make it of the correct size. Then you split it and then you go to chop. And finally, you get your direct chop technique. Now, troubleshooting and complications happen to all. No one has mastered anything without having problems. But remember that you as surgeons are, when you are left alone to manage a case, when in doubt, you convert. When in doubt, you please call for help. Learn for the masters and understand that beyond any doubt, the priority is the patient's eye. And I guess if you take all these points into consideration, understand that you're going to learn in a slow, stepwise manner, and you're not going to give up, and you're going to learn from everyone and be the best version of the surgeon that you can be and continue to grow even after you gain what you believe is expertise in this technique. I guess then you've got it all and you're all ready to fly. Make sure that you pay attention to detail, be meticulous, achieve consistency, and aim always at reducing tissue trauma. And remember, it is a slow, stepwise, guided learning based on the deep understanding of the principles of phacoemulsification. And then I believe you're all ready to fly. Thank you very much for your patient hearing.